Thank you so much, Joy, and thank you to all of you for having us here today. We are really just super excited to dig in with you on this topic. Humor me for 1 second, a year into the pandemic, and it's going to take me just a second to figure out how to get my slides going. Here we go. Excellent. Look at that. So our panel today is called Taking Social Determinants of Health to the Next Level. And what we hope to accomplish in the next hour and 10 minutes is to level set about what social determinants of health are and why it is so important, as Joy said, to address these upstream factors that impact health and well-being, both in the short term and over the lifespan. And they really are important, particularly when thinking about people who are pregnant and parenting, which is why we're doing this whole session on them. So over the course of this session, you'll hear how various sectors are shaping policy to address these upstream social determinants of health, including federal policies, including interventions through the healthcare system, through community-based organizations, through technology, and more. And we hope that you will walk away with a sense for how, as advocates for maternal mental health, you can engage in this conversation that is really transforming the healthcare system. So first, I'm going to level set with a really short PowerPoint to make sure we have a shared understanding of what we're talking about here and a common framework for addressing these factors. Then we'll hear from a truly amazing panel of experts who are helping shape the conversation and have unbelievable experience in serving people and addressing social determinants of health. So let's dig in. So very first, let's just name it. What are social determinants of health? What are we even talking about here? Very simply, social determinants of health are the conditions and situations where people live, learn, and work that impact a person's health, both in the short term and over the lifespan. Healthy People 2020, which is a really cool federal effort that provides science-based national objectives for improving the health of all Americans, built an organizing framework about social determinants of health. And they identified 5 key areas, including access to quality healthcare, economic stability, access to quality education, and neighborhood and community and social context. And these are the buckets of social determinants of health that surround an individual, their family, and their community. But let's get a little bit more granular about what this actually means. On the slide, you can see some very concrete examples of social determinants of health and what we're talking about. And they really help illustrate these upstream factors that contribute to a person's health. And what we have listed here are positive factors that build healthy and resilient outcomes. Safe housing, transportation, interactions that are free from discrimination and racism, communities that are free of violence. But of course, the opposites are also true. The upstream factors can negatively impact the health of individuals and community. Structural racism and discrimination, lack of safe and stable housing, all of these factors can have a negative impact on someone's health. And importantly, can have a short-term impact, but also a multi-generational impact on the health of individuals, families, and communities. And this is conversation about social determinants have really come into sharp focus over the last year with the COVID-19 pandemic. The pandemic has exacerbated the longstanding issues of isolation, of toxic stress, and other upstream factors like housing and lack of access to nutritious foods. The impacts, of course, are disproportionately felt by communities of color and individuals and families with low incomes. And so with that recognition, and with recognition for the impact of social determinants of health, it becomes crystal clear that to improve health, we have to address the upstream factors. We have to design programs and policies that intervene upstream and have early interventions, in addition to clinical approaches and interventions if we want to improve healthcare outcomes. And addressing social determinants of health is not only important for improving overall health, but also for reducing health disparities that are often rooted in social and economic disadvantages and structural racism. So addressing the upstream interventions also becomes a pathway for disrupting the health impacts of segregation, disenfranchisement, and disinvestment in basic services like housing, food, transportation in communities of color and for individuals with low incomes. And not for nothing and important in the healthcare system, addressing social determinants is also a really important key in efficient healthcare spending and in lowering healthcare costs overall, which, as we know, is a driving motivation in the healthcare system quite a bit. And that does work when you address social determinants of health. Today, our panelists will address and share their experiences with how social determinants of health impact people who are pregnant and parenting, and the innovative levers that they have seen and tools they have used to really address these upstream factors. This comes at a particularly good moment because there are, in fact, a number of initiatives to address social determinants within and outside the healthcare system. And that's what you're going to hear from the panel today. Outside the healthcare system, initiatives are starting to shape policies and practice to promote health and health equity. Within the healthcare system, we see the beginnings of multi-payer federal and state initiatives, as well as Medicaid-specific initiatives that focus on addressing social need. There are new models under the Centers for Medicare and Medicaid Innovation, under state Medicaid delivery systems, and a lot of really just interesting new options for state policymakers to consider in addressing social determinants of health. We're also seeing increased investment in community-based organizations and partnerships specifically designed between CBOs and healthcare systems to address the non-medical services and supports that are needed to improve health. We are seeing an increased effort to dedicate efforts to addressing structural racism and the bias that is implicit in the healthcare system, with an effort to address upstream factors, again, to bring early intervention, prevention in the short term and across the lifespan. And assisting this, and I'm particularly excited to showcase some of this in this panel, technology is playing a key role, particularly during the pandemic, in linking the systems of support together. Because my background is in Medicaid, and it's such an important and big source of funding for social services, I do just want to highlight that over the past 18 months or so, and then particularly in January, CMS has been really looking at different ways states can leverage existing flexibilities under Medicaid to cover supportive services and non-medical healthcare services. And they did recently issue some guidance to states on how to do this a little bit better. And then to all of you, there are handouts in the app. We encourage you to look at them, but we do want you to become advocates on behalf of this work. So as you listen to our panelists today, which we'll turn to now, think about the ways you can engage. Think about the pieces that really resonate for you so that you too can become a champion for addressing the factors that matter in the short term, over the lifespan, in improving health equity, and in addressing social determinants of health. So I spun through that as quickly as I could because while it is important to level set, what we really want to do here today is hear from our experts. So with that, I'd like to invite all of our panelists to turn on their cameras and join us. What we're going to do is a round of introductions where I'll let each member of our panel introduce themselves. Then we're going to go into a moderated session where we'll unpack a little bit more what is really happening in this space. It'll be, I think, just a great conversation. We're not taking questions, put them in the app and we'll follow them behind because I know this is going to be really thought-provoking and fun. So with that, I'm going to go ahead and let our panelists introduce themselves. I will call on them and then they'll have a minute or so to introduce themselves, their work, and really what brings them here to this conversation today. So to start, Bella, can we have you introduce yourself, please? Bella, you are muted, so I'm going to have you unmute yourself and then start again. Hello.
Thanks. Hi, I'm Bella Kirscher. I'm the Director of Research at Aunt Bertha, which is an online referral platform for social services in America. So we connect people seeking help to the social care providers that serve them with dignity and ease. And we work with lots of different organizations across the country, many of them health systems and health plans, to get people connected to help both their populations as well as getting their care managers, social workers, and others a tool that more easily helps them find resources and connect people. My background's mostly in healthcare. I used to work at a large health IT organization, big EMR system, Epic, and then moved on to community health. So I worked for a large federally qualified healthcare system here in Austin, and then moved over to population health. And so I've been at Aunt Bertha about 2.5 years supporting the company in policy related matters. And I'm really excited here today. I've been listening in on the sessions, looking forward to more, really from the policy point of view, but also from a personal point of view as well. Maternal mental health is very important to me. My mother died by suicide. And so the work that this group is doing, that all the folks, all of you all listening here are doing is really, really important to me personally. So I'm really thrilled to be here and can't wait to talk more about my work.
Excellent, thank you. Dr. Tandon.
Good morning, good afternoon, everyone. I'm Darius Tandon. I'm a faculty member at Northwestern University School of Medicine in Chicago. I am a psychologist by training, and I do a lot of intervention work focused on prevention of postpartum depression. A lot of our work has been done in the context of home visiting programs that serve pregnant women, women with young children. We have been working with an intervention called Mothers and Babies for over a decade now. It's an intervention that has multiple modalities, can be implemented by multiple types of individuals. And as it relates to the theme of this panel, Mothers and Babies, even though it is focused on prevention of postpartum depression, very much is framed as a stress management intervention. And many of the stressors that women in home visiting and other settings face are related to social determinants of health. So really looking forward to the conversation today.
Thank you so much. Dr. Rodriguez-Reynoso.
Hello, everyone. I'm so excited to be here. My name is Marianela Rodriguez. I am a clinical psychologist and I live in Puerto Rico. I've been working for the past 15 years with perinatal mental health here in Puerto Rico, from volunteer work to grassroots community-based organizations to private practice. I am currently a consultant for the Department of Health for the Title V home visiting program. So very interested in Darius' intervention as well. I also serve as a psychologist for a specialized clinic that cares for people, pregnant people living with HIV. And last year I got together with a researcher, academic, who's also a psychiatrist, and another colleague who's a clinical psychologist that has a long time experience within NICU, to create the first center for perinatal mental health in Puerto Rico. So I'm very excited to talk about it. I'm going to talk about it a little bit more in a breakout session later. But thank you. Excited to be here.
Wonderful. Kay.
Good morning, everybody. I'm Kay Matthews from the Shades of Blue Project, based in Houston, Texas, where we primarily focus on women of color and their maternal mental health. So we work with women before, during, and childbirth. And of course, again, our focus is maternal mental health, and social determinants of health is something that we wholeheartedly focus on in the organization. So I'm definitely looking forward to this conversation today.
Thanks, Kay. Melissa?
Hi, everyone. My name is Melissa Hanna. I'm co-founder and CEO of Mommy, which is a telehealth and care coordination platform focused on maternal and infant health. And we work with health systems, providers, and payers across the country to connect together healthcare ecosystems that support mothers and babies across the continuum of care from conception all the way through first year of life. The company is a software and services company in that we not only provide the perinatal connectivity technology to link together providers and community-based organizations, social service groups, and medical centers across a given region or healthcare ecosystem. But we also provide direct services through the platform to fill in the gaps in care where needed in areas including maternal mental health, infant feeding and lactation support, postpartum recovery, and prenatal counseling and education led by a clinical nursing staff in-house at our company. My background is in law, business, and policy, and that's part of what led me into this work. And the other thing that led me into this work was working with my own mother in this space, who is a pioneer in maternal health, designing some of the leading outpatient lactation and postpartum recovery programs in health systems across California. And those models have been replicated to other parts of the country as well. And so taking a page out of her book in designing those kinds of comprehensive programs, we started to build the Mommy platform to make that possible for other health systems to replicate and build those programs online.
Thank you, Melissa. And last but certainly not least, Ronnie.
Thank you. I'm excited to be here. My name is Dr. Kamalapi. I'm the CEO of Rivers Integrated Care, and we focus on providing services to electronic health record companies and providers, helping them operationalize the use of technology to better provide care and services and to ensure compliance with payer regulations. My background is in integrated care. I have a PhD in integrated care, and I'm very passionate about how emotions, behaviors, and stress affect physical health. In terms of social determinants of health, I have worked as a payer, working for a health plan, and also Arizona Medicaid. And one of the biggest challenges was seeing the impact of homelessness on the emergency room visits and how it was hard to help patients stay out of the emergency room, because some of them use it as a way to get meals and a way to sleep indoors. I'm very passionate about social determinants of health. So I've worked closely with providers and healthcare technology companies to build assessment tools, incorporate data gathering techniques and analytical tools on how to gather data and use that data to develop predictive, non-clinical information to proactively manage population health and improve outcomes. Thank you for having me.
You can see, everyone, why I am so excited for this conversation in this panel. This is a real powerhouse here. So let's dig in a little bit. Dr. Rodriguez, I'm going to start with you. In your practice, as you've already sort of opened the door here, you really get to see and to hear the direct impact of the social determinants of health on the people you serve. Can you tell us about what that experience is like as a provider, and how social determinants of health really present and what can be done about it? Big question, but go ahead and see. Let's start the conversation there.
Big question, yes, important though. And before I get into how it affects our clients and how I've seen it in our clients, I really want to put into perspective a little bit of the context of Puerto Rico, because not a lot of people may be familiar with, and the history and the social, political, and economic relationship that Puerto Rico has with the United States places it at a disadvantage for many services from the get-go, including healthcare services, as we're often perceived as second-class citizens. So we need to start with that. And on top of that, we need to look at our 5 years. We've had an unprecedented series of events that have affected our health. We started with it during the past 5 years. We started with the Zika epidemic that certainly hit hard our pregnant and postpartum population. And then in 2017, we had 2 hurricanes, category 5, 13 days within each other, that devastated the island and left us with insecure food insecurity and housing instability that we still see today. If we look around, we'll see housing with still the FEMA blue tarps on them. And devastated infrastructure as well. So all of that impacts our health. In 2019, we had political upheaval that resulted in the impeachment of our governor. And we started 2020 with an earthquake. And we were still feeling replicas of that earthquake when we started the lockdown in March for COVID-19. So it's been a very unique, adverse environmental factors that have impacted definitely our health and the health of our families. On top of that, when we speak about Hispanic or Latinx community, and specifically with the Puerto Rico, we need to look at the social norms and how and the values of a patriarchal society and how we view motherhood, which is a gender biased, almost mystified construct in our culture that adds an additional burden to mothers and families and the stigma. So with all of that, we really have been impacted. And what I see in my clients, I see high Caesarean rates that oscillates from 47 to 51%, which is outrageous if we know the World Health Organization's recommendations. We have a very high rate of preterm birth, as well as other chronic conditions like asthma and diabetes. But I don't want to end up in that note. I also want to say that the clients and families that I've been working with for the past years have really shown resilience with a capital R. And that's one of the things we really want to investigate in our center and find funding to look at how, what are the coping mechanisms and how, I mean, it's almost unbelievable with all this panorama that our babies are thriving, that our parents are parenting, and that we keep going on with all of this. So that's one of the missions of our centers and what we want to work in and look at that post-traumatic growth and see what else needs to be done to continue preparing for other emergencies.
Thank you so much, Dr. Rodriguez. And Dr. Tannen, I'm going to turn to you to build on that, because I'm sure while the Puerto Rico experience has a lot of unique factors, there's a lot of commonalities with what you see in your clinical practice. And if you could speak a little bit towards the interventions you mentioned, I'm particularly interested in the prevention lens of preventing adverse health effects and addressing the totality of circumstances that bring a person into your practice. Can you speak a little bit about what you've seen and what resonates in terms of the interventions?
Sure. So, I do think it's really important to have a conversation that is focused on both treatment and prevention, right? So oftentimes, not always, but oftentimes we are focused on women who perhaps are in greatest need, who are already exhibiting clinical depression, clinical anxiety. And certainly there is extreme value in working with those women, with that population. I do think that there is growing evidence that women who have mild to moderate depressive symptoms. We know that women who have mild to moderate depressive symptoms, number one, are at risk for developing, major depression, clinical depression in the future. So that's one reason to focus on preventive interventions. We also know that women who might be exhibiting mild to moderate symptoms, they have many of the same negative maternal and child health outcomes as women experiencing major depression. So if you think about engagement with children in terms of responsive parenting practices, we know that women who have mild to moderate symptoms are compromised in that aspect. So a lot of attention really does need to be placed on working with that group of women who right now might not meet criteria for full-blown, depression or anxiety. In terms of the intervention work that we do, a lot of it is in the context, as I mentioned earlier, of home visiting programs. I think the sort of guiding light, the North Star that guides a lot of our work is the idea that we want to bring mental health services and interventions into settings rather than relying on women having to seek out mental health access external to programs that they might be engaged in. Because home visiting occurs throughout the country and in multiple territories, we know that home visiting is a really viable setting for us to embed our mothers and babies intervention. And certainly the idea is that if we can build capacity within these home visiting programs, we're able to then not rely on external referrals to be available and for women to access those services, but to really try to intervene within the context of home visiting. So I'm happy to give some more specific examples of how we do our intervention work later, but want to turn the conversation over to my colleagues.
Thank you so much. And I think this provides an excellent foundation for the possibilities of working within the healthcare system and at the practice level to support the partnerships with the community-based organizations, the partnerships that will really propel us forward here. And so with that, I think it's a natural bridge, Kay, over to you, because you are working in the community directly with moms and providing that bridge support. And you're seeing firsthand the impact of the social determinants on women's lives, and then are working to help them solve it. I wonder if you could talk a little bit for us about what you see happening, what the role of the community-based organization is in getting moms the support they need. How does it work on the ground, and how does that interact with the healthcare system? Another big question, but let me tip it to you.
No, definitely looking through the lens of what role does the community-based organization play when it comes to social determinants of health. As an executive director, and before being an executive director, I'm always going to be an advocate, right? I think there's a gap that needs to be bridged between the healthcare systems and the community-based organizations. It has to be a collective effort. I say that these are my clients, but in the healthcare system, these are your patients. So when there are barriers that exist with your patient and the delivery of service that they may be receiving or not receiving, then they come to us, right? And they're our clients, and we're talking through these things, and we're talking through, well, I went to this doctor's office and this is what happened. I'm never going back there. Well, if we have a working relationship with them, maybe we can figure out what is happening, because typically in the communities, they're going to the clinics and the nearest hospitals, right? So there has to be a working relationship with the delivery of care system. That's first. Because when we think about social, the first thing that comes to mind for me with social determinants of health is the racism that exists, whether it is broadly or the racism that you feel when you go into these places, right? Typically, our moms are always, they lead with, I don't feel like I get to parent my own child. If I am feeling some type of way mentally, I'm not telling them. I don't know if they're going to report me or, are they going to put me in a mental hospital? These things are so consistent. I have been doing this work for 8 years now. And this is a consistent conversation when I get to talking about mental health. And if you're struggling mentally, what kind of support do you need? The first thing that comes to mind is, I don't want someone to take away my kids. So if that's going to happen, then I want to end this conversation. And so that's why I say, when I think about social determinants of health, I lead with racism. You cannot look at someone and determine whether or not they need something, right? For instance, just as an example, if there's a mom who always, every time she comes into your office, you feel like there's a problem. Have you thought about what it took for her to get to your office? Maybe she had to ride 2 or 3 buses to get there. She's dealing with all of these social things, and this in turn affects how she even gets healthcare. Sometimes we got to think that this is a person who is actually showing up to a doctor's appointment. What about the person that lets these things stop them from even attempting, right? So this is a lot of what I see in the work that we do, is we address those social issues. Like, this is really what social support is, addressing what's happening for full circle before we can even get to the mental part. Because if I'm worried about paying my rent, I'm certainly not going to sit here and have a conversation with you about my mental health. I'm sorry, that's not the most important thing, right? So when I offer social support services, hey, what's going on financially? What's going on at home? What's the whole family dynamic? And so if I can help a woman with that, then say, hey, we have these support groups that are centered just for you. Now I'm addressing her. So I've addressed her concerns and not just my concerns for her. And so when again we think about social determinants of health, we have to look at the whole dynamic. And yes, it includes food insecurities, all of those different things, but we don't get to skip when we address them. We have to do this blanketed across everybody who walks through our door, because just because we look a certain way doesn't mean that's what it is. So just stopping having these conversations. But again, that gap in community-based organizations and the healthcare system needs to be a collective effort.
Okay, thank you. There's so much to unpack there, but I think what you've done is among the things, the issues you've raised up, which I want everyone to be thinking about, is the how the healthcare system and the role it really can play in the external factors. What is the healthcare system's role in housing? What is the healthcare system's role in addressing food insecurity or community violence? And making those linkages and meeting those needs is not necessarily the role or the responsibility of the healthcare system, but it is an incomplete response unless we solve for that system. And so we're going to turn this panel a tiny bit to talk about some of the ways that systems are responding, and in particular, building the linkages across the providers and the healthcare systems and the community-based providers, and filling in some of those gaps. And it's a unique moment in that, and I think we've seen the proliferation of tools really happen over the past couple of years. So now we're going to lean in a little bit on these technological solutions that are not the answer to the bridges, but certainly play a critical role in filling in some of these gaps. So Melissa, I'm going to turn to you now to kick off the tools and technology part of this panel, to talk a little bit about how you see that, both through the implementation of the Mommy tool, but also given your broad background in this issue, what are the challenges and the opportunities here for technology to help fill in the gaps and to be the connective tissue between the healthcare system, the community-based organizations, and the women themselves? How does that all fit together in addressing social determinants of health?
Well, as you said, there's a lot to unpack here. And first, I have to agree that technology will not be the end-all, be-all solution to our challenges in this space, or broadly in the maternal and child healthcare field. This is always going to be about care, and it's going to be about people working together to center the experiences of mothers and be there in a proactive way to guide and support and advocate, rather than what we sort of have seen historically in the U.S. healthcare system, which is a reactive state, waiting for issues to come up and then being ready to jump in and solve them and fix them, rather than go upstream and prevent them from occurring in the first place. And we know why that happens. It's easier to track the fixes and the saves than it is to track the things that never happened, because we were there to support before the issues arose. The opportunity with technology is really in creating those linkages between the healthcare model, the clinical model of care, and the community-based organizations that are really doing the work on the ground in the community, in the neighborhood, and in many cases have the best sort of field of vision there about what's going on with patients, with the mother-baby dyad, with the family, and really just broadly with the very many things that can be mitigating factors in participation in care and access to care, in creating a trusting relationship with the care provider, and really can then affect the overall healthcare outcomes that we're trying to achieve. And as Kay shared, when those things are at play, it it becomes the whole story. It doesn't matter then how many other people are around ready to support and serve this mother, because there are so many other factors that need to be worked on first. And in many cases, what we find is that providers, although maybe aware and understanding that these things are happening, are otherwise incapacitated or disempowered from providing that support. That's not what your OBGYN does. That's not what your primary care provider does. But the first step is to provide that education and to really broadly create the awareness within the healthcare provider community that these are the factors that are affecting the overall outcomes here. And you can be the best at your job, but if you're not also understanding that this patient may be experiencing housing insecurity, food insecurity, may be taking multiple modes of transportation just to show up that day for what is going to be 15 minutes of FaceTime with you. If you're not taking all of that into account and then creating those channels to provide access to resources to solve for those factors, then you're not only disadvantaging the patient, but also disadvantaging your own care team in doing the work that you've set out to do. So what Mommy has done is create a bit of we say like a superhighway between those various facets of the healthcare and community-based ecosystem. The way that we implement is that we work with anchor organizations, whether those are large health systems, payers, large provider groups in a given region. And we do an audit with them on what's working and what's not working. Where do you currently have infrastructure, resources, care models that are working and are proving out the efficacy there that you've aimed for? And where are there gaps? And that really challenges people to take a hard look at what they have and maybe what is available, but they're not necessarily utilizing, which often is the relationship with the community-based organizations. That's usually what it comes down to. Oh yeah, we know that there's a community-based doula program. And we know that some of our moms are going there, but not everyone. Or we're aware that there may be some, even for example, now we're seeing in the midst of the pandemic, how many people don't have access to stable internet access, to have bandwidth, to be able to participate in virtual care. So when we hear providers say, you know, I don't know that she has internet access at her home. Well, let's solve for that then, because it doesn't matter how much your team invests in telemedicine, you're not going to be video calling with her today. And so really being very blunt and very honest about these things is the first step. And then after that audit occurs, going out into the community as our team does at Mommy and implementing that and bringing people together and understanding what kinds of programs can be sort of locked into place to create those reliable and consistent channels for referrals, so that it isn't just a business card on someone's counter at the clinic and you say, hey, you know, check this out, this may be a help to you, or a flyer or a poster on the wall, but is actually a warm handoff and manifests digitally the kind of communication that Kay shared needs to be happening in that ongoing communication between healthcare providers, licensed and certified healthcare professionals, and the community-based organizations and the professionals that they work with and staff to really be engaging in that ongoing conversation with the patient, because they often have many more touch points with your patient than the provider does. So, yeah.
Thank you for that. I think we'll unpack some of those pieces in just a minute more too, as we look at the real solutions. Bella, I'm going to turn to you now for another perspective on the technological tool. And one of the really cool things I think about Aunt Bertha is its hyper-local approach to connecting individuals with the services they need. Can you tell us a little bit about that work and how that is part of the solution to connecting people with the services they need?
Sure. Yeah. So, you know, at Aunt Bertha, our mission is to connect all people in need and the programs that serve them with dignity and ease. And so exactly what you say, what we realize is that people really want that hyper local access to those services. And so we have the platform out there. We run findhelp.org. Anybody can go for free to the site and put in their zip code and find a list of free and reduced cost social care programs. And so they can also easily and very quickly see right away how to connect to that program, be it going to a website, calling a phone number, filling out a form, making them a referral themselves. And so just like what Melissa said, we also really believe in that community engagement piece too. And so we work with, so we operate findhelp.org, which is that free site where people in need can get connected. But then we also work with a number of customers as well. So very similar to what Melissa said, we have healthcare systems, lots and lots of health plans, state governments, health education institutions. We also work with a number of mental health care organizations as well. So we work with To Write Love on Our Arms. We work with some organizations that are using Family Connects model, which is a postpartum nurse home visiting program for new parents. Because as you mentioned, Lena, earlier, there is this realization that people need to get connected. If we're going to take care of their health care and their mental health, they need to get connected to those social care programs. And they want to do it in their community. They want to do it where they know how to access the service. And so we have those customer organizations are using us in a couple of different ways. One, they often will have a public facing version of Aunt Bertha that's branded as their own. And we really believe in the power of self-navigation. Sometimes folks are dealing with issues that they aren't comfortable talking with their care manager or their physician or whoever's on their care team about. And so we want to provide a tool that allows them to anonymously search for help and identify resources in their area. And so a lot of times our customer organizations will set those the consumer facing sites up. And then they also will have kind of a staff facing site. So that site can be used, they can do assessments to really identify needs. And then their care managers, social workers, case managers, folks we call helpers, can then get their folks connected. So once they've assessed a person, they can then again get them connected more locally. And what comes out of all this, what we've really seen is that with all this information that our customers have, they suddenly get a better idea of what the needs are. So they assess their patient population or their member population or their student population and can really better understand. So, these folks who have this Medicaid plan, what do they need? Is it food? Is it housing? Is it transportation? And then they're also able to see with our data where they're able to get connected to help and where they're not. And that information has become really powerful as they start to set up their own programming. So we're seeing health insurance companies are now starting to realize, again, that social determinants of health is so important. They can use that information to say, okay, our mom population needs access to diapers. They keep looking for it and the diaper bank keeps running out. So maybe we should start a diaper program. And we've actually seen some health insurance companies start to do that. Or they also know that where they can go and start to develop partnerships in the community as well. So again, if they know there's a need for diapers, maybe we have a partnership with the local diaper bank or with the food pantry that can provide formula. And so all that has become really helpful for them to better understand their populations, better design some of this work as well. And the other thing that we're really excited to see is there's now a lot of cross-sector collaboration across the country happening. When we talk about social determinants of health, what we're really talking about is poverty, right? We call it social determinants, but really it's not, healthcare can't fix this alone. And so what's been really inspiring is where we're seeing in communities, sectors start to come together. So education starting to come together with workforce, with state government or local government, with healthcare, with health plans. And so we're really excited to see that cross-sector collaboration happening because I think it's going to be critical to that. And just as you said, we feel like we're the connective tissue to help connect all these parts and pieces. And if we can be an excuse for folks to get in a room and talk about this stuff, we're really happy to do that. So.
Thank you so much. Okay, Dr. Kamalafi, you're last here. And you've heard the provider perspective, the community-based organization perspective, the technological perspective. I'd love, with your big picture lens, sort of across the systems, talk a little bit about how this all fits together and any other innovative either tech solutions or systems solutions that you see really coming together to make change and to address social determinants of health? What are the other promising practices that we should just lift up as thinking about this?
Thank you, Lena. And I completely agree with Melissa and Bella. There's a lot technology can do, and there's a limit to what technology can do. This is a community effort. We all have to come together from a payer perspective, from a provider perspective, from a patient perspective, to all work together. With the emergence of the pandemic, I've been seeing a trend called digital social determinants of health. And what we are seeing is, although there's a lot of technology transformation and there's a lot technology can do, we have to address the technology from the perspective of the patient. How is this technology being created to help the patient? And CMS, the Center for Medicare and Medicaid Services, has been very innovative. Back in 2016, they created the 21st Century Act. The 21st Century Act is a law that came into place saying technology needs to be developed to address patient care from a patient perspective. And patients should be given the option to access the information through technology without blocking the information. As we speed up to 2020 and with the pandemic, what we are seeing is there's still a lot of challenges in terms of telehealth and in terms of how patients can navigate these resources to help with social determinants of health. From a technology perspective, what technology some of the clients I've worked with from a provider perspective have done is they have taken social determinants of health assessment tools and integrate that into their electronic health record system. So what this does is, as soon as a patient comes in, there's a prompt that reminds the case managers and the care coordinators to ask certain questions from a social determinant of health perspective. And then there's a resource integrated into the electronic health record that automatically helps the case manager or care coordinator identify resources that can help the patient from the patient perspective. A lot of more advanced healthcare technology companies also have this in the patient portal. Some people don't, some people do. But what we found out is this helps to gather the social determinants of health data from a patient perspective. And then it helps the provider to develop a way of following up, not just referring the patient, but working directly with community organizations like Aunt Bella and Case Company, and try to work with them in a way where the information can be sent to them in form of a referral, and they can coordinate and say, did the patient follow up? The patient wasn't able to follow up. They don't have a phone. They don't have transportation. It's then up to the provider or the payer to help coordinate how the patient can truly follow up with a provider organization. From a payer perspective, which has been tremendous and it's very exciting to see. Last year, about September, October, I did an analysis of the Medicaid system across the country. Social determinants of health was included in about 34 1115 waivers. And 1115 waivers is an opportunity for Medicaid organizations, agencies across the country to talk to reach out to CMS and say, we're identifying areas in our community and our states that Medicaid doesn't cover, and how can we address this? Social determinants of health in partnership with community health organization was one of the forefronts that I noticed in the 1115 waiver. And from a technology perspective, that brings me in to say, do we have the resources to support the payer to get the information they need to ensure the providers are doing this? And do providers have the information they need, both from an assessment perspective, population health management perspective, and engaging the patient perspective to make sure that they can deliver care? So give example, Rovi Care is a software solution that coordinates this really well. When a patient goes into the hospital, there's an assessment that's done, and the assessment helps to identify there's a social need, an environmental need, literacy need, and the different social stresses that the patient might be going through, which might impact the patient and lead to readmission. Once this is identified, they then reach out to community agencies to partner with them to ensure that as the patient is discharged, that the social worker from the hospital and from the provider organization can engage with these community organizations to ensure a smooth transition of care, to ensure there's no readmission. And this software came about because about 54% of the patients going back into the hospital were going back into the hospital due to social stressors. They are not able to follow up on their care. They are not able to get the care they need due to social determinants of health. So from a payer perspective, payers are working to make sure that this has been addressed. But in terms of maternal health, a lot still needs to be done. Banner Health in Arizona just rolled out a technology system to ensure that mothers, right from when they have babies and right from the hospital, begin to get direct text message from a care coordinator who is an RN and can follow them all through, not just for 3 months, but for 12 months. They got a grant to do this, and we're hoping that with the use of technology, they can truly help mothers through their both physical and mental health perspective as they raise their kids. I hope that answers your question, Lena.
It did. And I mean, clearly, I'm throwing big questions at everyone. And so I appreciate both the diversity of answers, but also really the richness of the information that's been provided so far. So we still have a little time to dig in. And I think what I'd like to focus on sort of the brass tacks about how we make progress. I think what we have really heard is the story of an increased acknowledgement of the role of the upstream factors in healthcare and healthcare outcomes. I think we have heard a lot about the different pieces that are contributing to the progress we have made so far. But what else really needs to happen to get the players to work together, to get the investments? So what is needed? So I'm going to start, I think this question goes Dr. Tandon, Melissa, Dr. Rodriguez, and then anyone, but what, from a provider perspective, thinking about the healthcare system, thinking about the healthcare providers, what is the appropriate role and what is needed from the healthcare system to lean in more and to make addressing social determinants of health easier, more accessible, and more prevalent in terms of practice? And because I'm not narrowing my questions yet, what can you think of any particular role for federal, state, local policymakers in supporting that? Big question. I'll let you all jump in there.
I can share some thoughts.
Please do.
And some real world examples as well from our work. So first, just thinking about where providers fit into all of these different points that we've discussed, and understanding that much of what we're talking about really doesn't actually relate to the training that you get in pursuing a degree in healthcare and in sort of clinical profession. So, first acknowledging that and recognizing that much of the conversation we've had around this work over the past decade has been maybe, I would say, unfortunately misinterpreted as more burdens to put on the provider, more things for the provider to do. And whether or not that's really what we've all asked for and wanted in this space, a lot of it has been interpreted that way, and in many cases, rejected as, I can't do that. I don't have time to talk about that issue, that topic with my patient. I barely have enough time to get through what it is that I am mandated to do during this part of the, this stage in care. And so much of this really needs to come out during the prenatal period that, there's just a lot there to unpack in ensuring that there's a healthy pregnancy and a healthy and safe childbirth experience here leading into postpartum, because we see that all of this can really pile up if not addressed in the prenatal period and immediately start to change the nature of the postpartum experience and become a risk factor for postpartum mental health concerns. So right away, one thing that we do is talk about the scope of the provider role. An example of where we've been able to have an impact in increasing the conversation around social determinants of health without increasing the burden that clinical providers have on doing that work is in really sort of revealing all of the things that are happening outside of the building that can become immediately valuable resources in shaping this course of care. So again, sort of just showing what else is going on outside of your building and what is available to your patient. Now, an example of where that challenge really can be seen is in introducing platforms like Mommy. So we're not, I'll say, we're not strangers to challenges in getting technology in place within healthcare. And we know that there's reticence in using new tools and more things to log into every day. In introducing a telehealth model for the prenatal population that is receiving care through Los Angeles County Department of Health Services, for example, the first question was, well, how are we going to get patients enrolled in being able to have access to video calling and telehealth tools and online education as it relates to the prenatal care itself, and also to mitigating risk around social determinants of health? How are we going to even get patients enrolled? And we said that this should happen at intake. It should happen as part of that initial audit. And just as has been discussed here, in being able to say, well, let's talk about your care and you know, things related to your healthcare experience, but also let's talk about your needs at home and in your community. And initially, the numbers around enrollment were around 20%, as in 20% of patients were actually getting enrolled into the Mommy platform to be able to access these kinds of resources. And the programs, whether home visiting programs, smoking cessation, doula care, prenatal coaching, and talking about housing services, food services, all of these kinds of things, getting access to this, only 20% of the patients were enrolling. So we actually did it on-site. Our team came in full PPE geared up. This was in the middle of the pandemic last year, to understand what was happening in the clinic setting, because they said, well, we're getting patients enrolled at intake, but only 20% are signing up. What we found was that in that conversation with the patient, not everyone was actually getting pointedly asked, do you want access to this? Would you like to sign up? And in fact, some people weren't being asked this at all because there was already a prejudgment made that this person was not likely to get involved or be engaged. They haven't been participating in care up until date, and so they probably aren't going to do anything further than this. And maybe it didn't look like they had maybe a smartphone or access to internet, or they lived in a neighborhood that had, you know, spotty service already. And so someone was making a judgment to say, she's probably not going to get involved anyway. I won't even mention it. Working with the team, unpacking these biases, because frankly, that's what they were, before the patient even had a chance to choose whether or not she wanted access to these kinds of services and programs, unpacking all of that and saying, what if we just tried for the next couple of weeks to invite in an excited manner, in a loving way, everyone to participate and say, this is available to you. This is free. This is here for you. If you want it, if you don't, that's okay. Do you want to sign up? 80% enrollment. This is the change. This is what happens once you start to talk with providers and work and understand what are the things that are happening in this setting that may be even also contributing to the lack of access, the lack of participation. And so that was an immediate transformation. On the other end, a lot of this has to do with making sure that there are care coordinators wherever your program exists in this space, the connectivity, whether you're using a platform like Mommy or Aunt Bertha, or you've built something internal for your team. Understanding that it's not enough to just send an electronic message or a phone number and say, call here, or a site and say, sign up online, but actually to have someone who picks up the phone and says, how's it going? Were you able to make that appointment? Do you want me to help? Do you want me to call and see if I can help coordinate that? And one final quick story on this, a patient that had sent a message through the Mommy platform to our virtual nursing staff asking for help. This was the message. I don't think my baby knows who I am. She's 3 weeks old and she cries every time I hold her. I don't think she realizes I'm her mother. Maybe because I had a C-section and we were separated at birth. Could that be it? And this was her first outcry. This was not something that had come up in conversation yet with any other provider. So of course, then being able to have that conversation, having staff that's trained and trauma-informed to be able to engage and understand where to route this patient, to get this patient back into care and into a mental health support program was the next step. We're still in contact. We're still working with this patient who's got a baby now who's several months old. But to continue to support the participation and link the rest of the team together, because those kinds of messages will come, and you need to be prepared to get that patient access to those services if they actually sign up and ask for help.
Any other thoughts on the provider's role? And then we'll switch to the role of community-based organizations and what they need.
Yeah, I'll just chime in, and I think my comment is probably relevant for both clinical and community-based organizations. I think one of the challenges is that providers feel overwhelmed that they have to respond to so many individuals, so many cases. And I think a philosophy that may be important to think about is sort of this notion of stepped care. For folks who aren't familiar with stepped care approaches, it's essentially starting with sort of lower intensity, interventions, and then stepping up as, women may need more intensive services. And there are certainly a lot of really, really effective services, supports, whether they might be, calling a hotline, accessing technology online that could be done for individuals who are at sort of a lower symptom level. So I think if we acknowledge that a service provider does not need to respond to everybody in the same way, I think that is really helpful. And there are certainly a wealth of resources to be able to respond to individuals who might be presenting with more mild to moderate symptoms. And then we can leave, the more intensive cases, to providers who may have, greater bandwidth to access that population.
So, oh, sorry, Bella, go ahead.
Oh, I was just also going to say, I think the other model that we have seen be fairly successful is the community health worker model. So again, it's the extension of the care team and having folks actually in the community that really understand the patients well. And so that model's become really popular. But I do think, as both Darius and Melissa mentioned, the providers are overburdened with technology, with care. And so what are the ways that we can make it easier or incentivize them? We've also seen health plans start to incentivize assessing patients for social determinants of care. So for a long time, physicians have been paid to do depression screening or tobacco screening and others. And now we're starting to see that some plans are getting into actually paying for assessing the patient, and then they can then take over their care management team, that the health plan employees can then take over the actual routing and helping get that patient connected to those services. So I think there are lots of different models to help, again, kind of keep the burden off of the provider, given that they have so much going on. And I think we're going to get to policy stuff too, if we have time, because I think that's an important piece as well.
Dr. Rodriguez, did you want to lean in here?
Yes. I just wanted to jump in and mention the importance of the holistic approach and integrating. I think we're still, at least from our perspective in Puerto Rico, the care of pregnant and postpartum people are still fragmented and just viewed from a physical point of view. And we'll do all kinds of screening regarding the physical conditions, but never think about social determinants of health or perinatal mood and anxiety disorders or mental health wellness, and advocacy, awareness, and just breaking that or reconstructing that training of our providers. I think it's really important to continue to integrate communication and just that holistic care is key.
Yes. So thank you all for tackling that big question. I'm going to switch the lens now about 180 degrees and think about the perspective of the community-based organization, because a lot of the partnerships between the healthcare system and the CBOs relies on a culturally and linguistically sensitive CBO workforce there to catch these referrals and to be partners with Aunt Bertha, to be there to help people on the ground. And Kay, what types of supports do the community-based organizations need in order to be there, to be good partners, to serve the patients who are referred from the healthcare system? In what ways do the CBOs need more, and what does that look like? Or maybe you're perfectly resourced and it all works out.
Yeah, in a perfect world, Lena, that's not what it is. Of course, funding is always a barrier, but the biggest piece here is relationships. Oftentimes, we're not building relationships. We have to actually see the value in community based organizations. If you don't see the value, then you cannot make the connection as to why they are important. So, first, it's about valuing what community based organizations bring to the table. Again, our clients are your patients. That's the relationship piece that starts it off, right? And from there, we can build out this real true relationship, and it works because I know a lot of times we sit and we talk about the issue, but this is the solution. This is something that I don't just talk about, that I do. The hospital systems and the clinics in our areas, we have relationships with them. So when these issues do arrive, or they're having it, trying to get a better understanding of what the doctor may be telling them, what the nurse may have told them, the interaction just full circle, we have someone there that we can reach out to, and maybe do some case management, some resolution as to the hospital system or the care system needs the patient just as much as the patients need them, right? But that's relationship building. It's taking 1 or 90 seconds out of that 7 minutes that you have that interact with them and inserting some type of compassion. When compassion is inserted into any delivery care system, the outcome is so much better. And that's it. I really feel like wholeheartedly it's the relationship building. Of course, funding, when you think about the magnitude of how community-based organizations serve in the community, oftentimes we are underfunded, but we still do the work. That's been a passive thing. That's something that needs to be corrected. When you find a community-based organization that is actually doing the work, think of them when you're planning your grants and things like that. Include them in it and think of them as something bigger than just your subcontractor. Just being honest, like, we are doing the work, we are on the ground, and we just need more to be able to do a little bit more and take care of the people that are out here on the ground doing the work. So that's my perspective on that.
Yeah, and just to add to that, Lena, I completely agree with Kay. One of the challenges identified from a payer perspective is that hospitals and clinicians are not asking the right questions to help patients identify social determinants of health or even help them follow up. So CMS released the Z codes, ICD codes to help providers bill for asking and following through with social determinants of health, to help providers be more motivated to help patients engage with community organizations. Unfortunately, even though those codes have been released for the last 5 years, a lot of hospitals and providers are still not aware or comfortable using them. So it's really up to the payers, the health insurance companies, to really educate their providers through their provider manuals, forums, however they choose to do it, to let them know if you do follow through, you will get paid for it. And it's also included in their policies and their contracts. As we are seeing through the Medicaid spectrum, Medicaid is not including that in all the value-based contracts they're giving to their Medicaid managed care organizations. CMS is also moving towards that direction. But on the commercial and on the private payer side, which is where we're seeing a lot of the suicides and the mental health issues happening with moms, we're not doing a good job helping mothers through that spectrum. So hopefully, as policies are being released, as payers keep continuing to work towards having a maternal health case management program, that they can really work towards helping the providers know they can bill for it and making sure they get paid for really coordinating social determinants of health, because that's where you can truly treat the patient as a whole by helping them address their source of their stress. The source of the stress will lead to a mental health diagnosis, which will in turn affect their physical health issues, or even vice versa. So treating the patient as a whole includes addressing social determinants of health and making sure providers are being paid for it. And community organizations do have the funding needed to help address and help providers and patients.
So I think that is, we are out of time, but I think that is a really nice summation of where we'll need to land. It's the recognition of all of the different players who need to be engaged, who need to be appropriately reimbursed for their time, and who have a role and a responsibility of putting the moms at the center of this care and providing the holistic support around them. The only thing we didn't get to, and I'll just put a nod to it before I turn this back to Joy, is the role of all of you in the audience as advocates for addressing social determinants of health. I think listening to the diversity of perspectives on this panel, it's extremely clear that every sector has a role to play in advocating for appropriate funding for connections. And we encourage you to find the ways you want to engage. And we have resources in the app, which provides some easy answers, and continuing to look for those solutions and the ways to be advocates for addressing upstream factors will continue to be important as we move this policy solution forward. With that, Joy, we're 1 minute over and I'll turn it back to you.